Hi, everyone. So today we are going to talk in the first part of a three-part little lecture about drug interactions and pharmacokinetics. So let's get started with Pharmacokinetics 101. Now, pharmacokinetics, as any big word, might be a little bit intimidating at first, but what we'd like to focus on with PK, as we know it, is PK is the study of what the body does to a drug after it enters the body. So PK is just the abbreviation for pharmacokinetics. In pharmacy school, you would get a whole class on pharmacokinetics. So I had a whole 2 semesters on PK. Lucky for you guys, you only get this one lecture. So pharmacokinetics, again, big word to just explain what the body does to a drug once it enters the body. We want to know what happens from the time that the drug enters to the time that it is excreted through whatever means necessary for it to leave the body. Now, a term that will also come up with PK is what's known as bioavailability. So bioavailability is the rate or extent that a drug can be absorbed by the body to have an effect. So what does this mean? A good way to put it into perspective is the reason why we have either an oral dosage forms like a tablet, a pill, or something like that, versus why some drugs might need to be intravenous, IV. So oral drugs are what's known as orally bioavailable, meaning they can be taken by mouth and then absorbed into the body, taken through the mouth. So goes to the stomach, goes through the liver after being ingested, goes into the gut and gets absorbed that way. Those are orally bioavailable drugs. Now, we get into a problem with some drugs that might be pretty big or complex molecules. For instance, this guy right here, I forget from the time when I was making the PowerPoint, but it's a chemotherapy drug. It's either, I believe it's Excretion. And this, as you can see, you don't have to be an organic chemist or a pharmacologist to understand that this is a very, very a difficult structure to synthesize within a lab or to create manually. And it's very, very, of course, fragile if it were to be absorbed through the mouth. So you could ingest vincristine, but it wouldn't have any sort of therapeutic effect because it would be destroyed in what's called that first pass metabolism, meaning it is not orally bioavailable. You can only give vincristine and some of these other drugs intravenously. And as I said down there, IV drugs are usually not orally bioavailable, so they have to be administered straight into the bloodstream in order to work. Now, all drugs go through a 4-step process during their journey through the body. So these 4 steps are known as ADME or ADME. That's what the common abbreviation is. And that is the basis for all pharmacokinetics that goes on in the human body. So what is ADME? Let's look at it. So first of all, with A, we have absorption. So absorption is just how the drug moves from the site of administration to the site of action. Now, what is the site of administration and what is the site of action? Well, the site of administration is where the drug enters the body. So it could be orally, like I was talking about on the other slide. It could be IV, intravenous, so you might get it through, as you see right here, just through a IV in the arm. Could be subcutaneous, into the fat just under the skin. Multiple others, it could be a patch, it could be a nasal spray, you name it. However, it is first administered into the body. That is how it is absorbed, and that's the first step of pharmacokinetics. The next step of PK would be distribution. So that's our D in ADME. And that's the journey of the drug from the bloodstream to the tissues of the body. So drugs, once they get absorbed, once they enter the body, they have to be transported to where they need to produce a therapeutic effect. So if you have a psych drug, for instance, a psychiatric drug that's supposed to be working in the brain, if you take it orally, it's going to be metabolized usually through your liver and through your gut. It's going to get into the bloodstream, and the journey through that bloodstream, through that blood-brain barrier into the brain is exactly what the distribution process of that drug would be. Metabolism is our next step. That's the M in ADME. And it's the process that breaks down the drug in the body. So this is going to be the most important process that we talk about in terms of drug interactions. And then lastly, we have excretion, sometimes also known as elimination. And that is simply the removal of the drug from the body. So how is the drug cleared out of the body? In layman's terms, do you pee it out? Do you excrete it through feces? Is it simply stored in the body for a long period of time? How long does it stay in the body after it's been administered? Those all have to do with excretion or elimination and that final step of pharmacokinetics. And just to put it into perspective for our visual learners out there, I'm one of them, so I usually like to include these things. Let's say the drug is orally bioavailable, right? So we're taking this pill and we're putting it in through the mouth, and absorption, how will it get in? Well, it's going to go down into the stomach, and then it is going to go into the gut, and next we have our distribution. Usually goes down into the stomach, the gut, and then it gets filtered through the liver. That's where the majority of our absorption takes place for many, many drugs. So now the liver and the blood that gets flowing through the liver with this drug in it, it gets carried throughout the body and into various tissues via transporters or what have you. So that's how we get to distribution. It's where will this drug go? So you can see these little arrows distributing the drug all through the body, through the tissues, going to wherever it needs to go. Next, we have its metabolism. So how is that drug broken down? So how is that the drug broken down into potentially a more usable chemical or a therapeutic chemical? Because many times drugs are administered and they're not necessarily useful until they reach the liver and are effectively absorbed and effectively metabolized in the liver, which we'll talk about a bit later on. And then lastly, we have how does it leave? How is that drug excreted? And usually it's through either the urinary tract elimination, through the digestive system. Sometimes simply it's just eliminated within bodily processes or metabolism itself. So let's talk a little bit more about drug metabolism. Now, metabolism, again, it's a fairly technical word for a very, very basic thing. Metabolism is simply the chemical alteration or the chemical breakdown of drugs in the body. You can sort of see it from this flow chart that is much more complicated than anything you guys would need to know, but through various processes in the body, like for instance, this is a drug, sometimes the drug gets oxidized through a chemical reaction and it gets turned into metabolites. And those metabolites might be useful, they might not be, but either way, they can be eventually eliminated through, in this case, renal elimination through the urine. Now, substances resulting from drug metabolism, so as that pill is taken into the body and broken down into its individual chemicals, those substances are called metabolites. So they're the individual substances that you get from a drug. Now, active metabolites are what we really worry about in pharmacy. They're the ones that produce a therapeutic effect. So the active metabolites, otherwise known as, say, the pharmacophores, for another technical term, but the active metabolites are the active part of the drug, which is actively trying to produce some sort of therapeutic effect. Now, we also have our inactive metabolites, and they don't produce any sort of therapeutic effect. So as you can imagine, and I'll show on the other slide as well, drugs are very, very complex molecules, and many times you might have fillers within, say, a tablet. So that tablet might go in and yes, we have the drug, or it might be a salt of the drug. So the drug ends up dissociating from the salt that it's attached to. So it's easier to administer into the body. And the inactive metabolite would be whatever salt is left over after it's been stripped from that actual active metabolite within the drug. So the inactive metabolites don't produce any therapeutic effect, although occasionally they may be responsible for certain toxicities if they happen to build up in the body. So we have to be careful with our inactive metabolites, just as we're careful with monitoring the active metabolites and their therapeutic effects. Now, a little bit of an offshoot from the idea of active and inactive metabolites are what's called prodrugs. Prodrugs are administered in their inactive form, but they're later metabolized into their active form by drug metabolizing enzymes. Now, what does this mean? It's kind of like a little Trojan horse almost. So if you know the story of the Trojan horse, how it got into it was a bunch of basically the soldiers were hiding inside the horse, right? And it wasn't active until that bridge or whatever, that trap door came out of the horse, and then they were able to invade the city after the Trojan horse was let in, right? So that's kind of like what prodrugs are. Prodrugs, they are first inactive. Like if you were to synthesize them and try to look at their properties without having them go into the body, they don't really work. For instance, clopidogrel or Plavix is a prodrug. Now, Plavix, in its form that you take as the tablet, completely inactive. If you were to synthesize that compound outside of the body, it doesn't have any sort of effect as an antiplatelet medication. However, once it gets metabolized within the body, it goes from being an inactive metabolite to an active metabolite. Plavix goes from being an inactive chemical to becoming actively able to produce a therapeutic effect. And that's why it's a prodrug, because it has to be changed by some bodily process in order for it to work. So and what changes it, you may ask? Most drugs, that is, are metabolized by enzymes. So enzymes are the things that would affect those prodrugs. And indeed, any drug during drug metabolism. And enzymes are simply large proteins, usually in the liver, which bind to drugs. Now, what do they do once they bind to drugs? Well, I have this very cute cartoon that you can get to see. So the basis of how enzymes work, and they work not just for drugs, but for other compounds in the body as well. Certain foods might be broken down by enzymes, especially in the stomach or the GI tract, and you name it. But the basis of an enzyme, this is the enzyme protein right here, this big purple guy. And the substrate fits into the enzyme. The substrate is the thing that the enzyme wants to break down or modify in some way. So in our case, for our purposes, the substrate is the drug. So whatever drug needs to be metabolized, it acts as a substrate to a specific drug metabolizing enzyme. So the substrate, our drug, fits into what's called the active site of the enzyme, and it fits sort of like a lock and key. Now, it fits like a key, and really the active site only takes very specifically shaped molecules, in this case, drug molecules that are specifically designed to fit into those enzymes, so they're metabolized and they have a therapeutic effect in the body. Now, when they come together, we have what's called the enzyme substrate complex. So that's simply when the enzyme fits together like that lock and key with the substrate, and that's how you get the enzyme substrate complex. So the drug fits into the enzyme right there. Next, what the enzyme does when it gets a hold of that drug is it starts to modify it structurally. So it might change where a few molecules are placed, or a few methyl groups or other chemical parts of that substance are placed. And that's just part of the work of the enzyme. The enzyme sort of, you plug in the materials and you get a different product that comes out of it. So the enzyme will break down in some way the substrate as it's attached there. And you can see the product that you're getting right there is split into, in this case, two different things. The enzyme helps modify it, and then when it lets it go, you get the product, which has now been separated into two separate things. So if we're looking at a drug, it might be separated into its active metabolite. Let's say the active metabolite is that teal bluish one over here, and maybe the inactive metabolite, that waste product that we're just going to excrete and get rid of eventually, is that purple waste product over there. So that's how we start off with, say, a prodrug or any sort of drug, and you metabolize it through that enzymatic metabolism, through the metabolism that is rooted in those enzymes in the liver. We go from the substrate to the enzyme substrate complex, break it up into the product, and then release that product so it can be absorbed and do its healing or therapeutic effect. So that is the basis of how enzymes, especially our drug metabolizing enzymes, would break down a drug. Now, the most common drug metabolizing enzymes that we would end up seeing in pharmacy are what's called our CYP450 enzymes, because they're responsible for metabolizing or breaking down about 70 to 80% of all the medications on the market right now. So just think about even like the top 200 drugs that you had to learn, the large majority of those are broken down in some way through our CYP450 enzymes. As you can tell, but if you're reading this slide, but as you can tell, CYP is pronounced as CYP. So you'll hear about CYPs and CYP-inducing things, and that's all that means. The most common CYPs enzymes that break down these drugs are CYP3A4, which accounts for about 30% of CYP metabolized drugs. We also have CYP2D6, which is just under 30%. And there's a few others that aren't as common, but are still, again, they make up that 70 to 80% of CYP metabolism of all medications. CYP2C9, CYP2C19, and CYP1A2 are all very common CYP enzymes. Now, certain medications may increase the ability of CYP450 enzymes to break down the drug, and that decreases the effect of the drug. So those are known as CYP450 inducers. Now, I understand it's a concept that you have to sort of think about, but it makes sense. So let's follow along with this. So CYP450 inducers, they induce those enzymes to be more effective at breaking down the drugs. So it gives those enzymes like a power charge or like a speed bonus almost. It makes them much more efficient at breaking down the drugs than they otherwise would have been. So if we have an inducer that's affecting a CYP450 enzyme, it's going to decrease the effect of the drug that is normally cleared through that enzyme. So it makes sense, right? Because if a drug is normally metabolized by that enzyme and it's metabolized in a certain amount of time, say it's in the body for maybe 8 hours on average. If the drug suddenly encounters these more rapidly metabolizing enzymes, it's not going to stay in the body for 8 hours. It might only stay in the body for 4 hours. Now, that's half the amount of time it would normally have to produce any sort of therapeutic benefit for the patient. So say if it's a blood pressure drug or something that's normally cleared through those CYP enzymes, and suddenly we introduce a CYP inducer, and that starts affecting the enzymes that are supposed to metabolize that blood pressure medication, that blood pressure medication might only work for half as long as it's supposed to, and that could cause issues for the patient because they're not going to have their blood pressure be decreased. They're not going to have their hypertension treated as effectively because the drug is not working for as long as it's supposed to, because it's being eliminated from the body too quickly because of the presence of that CYP inducer. Now, on the opposite side of the coin, we also have certain medications or substances which may decrease the ability of CYP450 enzymes to break down the drug. So therefore, that would increase the effect, the toxicity, or the side effects of the drug. And those are known as CYP450 inhibitors. So CYP450 inhibitors, they would keep the drug in the serum or in the blood floating around for longer than it should be. What does that do? That increases the concentration of the drug within the body. Now, normally, sure, it's good to have the drug stick around in the body. We don't want inducers for the opposite reason, right? Because the inducers would eliminate the drug from the body before it gets a chance to work. But inhibitors can be difficult because they can keep the drugs in the body for too long. So say if you're taking a medication that is supposed to be dosed once a day, for instance, cholesterol medications. So your statins, you would only take them once a day. So like an atorvastatin, a Lipitor, that sort of thing. You'd only take them once a day. However, if you were taking certain substances or medications that might inhibit CYP450 from working properly to eliminate those drugs in a timely manner, so that by the time you take your next dose of the Lipitor, the next dose of the statin, that you're at a therapeutic, as you would say, low. So it is time actually for the next dose. If you keep taking that medication and it just keeps building up and building up and building up in your system longer than the 24 hours, maybe it stays in your system for 36 hours instead, that's when you start running into toxicity, because you have too much of the drug that's hanging out in your body, not being metabolized, so it's not getting to its therapeutic effect. Therefore, you're having issues because you're going to have even potentially an overdose situation in some cases where these inhibitors are extremely inhibitory and extremely effective against the CYPs experiencing this type of metabolism. Now, another way to visualize this, sort of how these CYPs work and actually, these enzymes work and actually accept the medications, or how these inhibitors might block them, is this picture over here. So at first this looks really, really complicated, but it's actually quite simple. So look at the binding site on the CYP enzyme. So this is our CYP enzyme. This could be CYP450. This could be CYP3A4. It could be CYP2D6, CYP2C9. Doesn't really matter, whichever one it is. Let's just say it's a CYP enzyme, a generic CYP enzyme. Now, a CYP inhibitor, so remember, the CYP inhibitor, it's decreasing the ability of the CYP to actually metabolize the drug that it's supposed to be metabolizing. So that CYP inhibitor is shown in the green right there. And it's attaching, if we remember our previous slide, it's attaching to the active site. So that CYP inhibitor is like a little lock and key attaching to the active site. And you can see it up here. It's shown in the green, and the blue is the active site on the enzyme, and the black is our drug. The black is this little drug right here. So normally what the drug wants to do this. It wants to bind to that active site so it can be metabolized by the enzyme and then have its therapeutic effect. What ends up happening though is when we have that inhibitor in there, it's like having a key already in the lock. The drug can't reach and it can't attach to the enzyme because there's already that inhibitor blocking it from attaching. So what does it do? It just stays in the blood and builds up there. And that's why we might have more toxicity or more side effects, because you have greater concentrations of the drug that are not being cleared by that enzyme. So the drug can't be metabolized by the enzyme because the inhibitor is blocking where it can attach. So it's like having another key in the lock. Like you can't put two keys in one lock. So it is stopping that drug from being metabolized, and that's where we have problems with the inhibitors. Now, inhibition or induction can cause a number of what are called interactions. These can be drug-drug interactions, they can be drug-food interactions, or they can be drug-disease interactions. Now, drug-drug interactions are what we will spend the majority of time talking about. They are what occurs when two or more medications are taken together and cause a desirable or adverse effect. Now, one might think, well, we're always checking for drug interactions. Drug interactions can actually be desirable. Yes, actually. So for instance, HIV combination drugs, so Biktarvy, Truvada, that kind of thing, many times they include multiple different types of drugs, one of which is actually useful in helping the absorption of the drug. And so it's easier for those drugs to have a therapeutic effect at lower doses. So it lowers the amount of side effects that might be experienced by the patient, especially when you're able to use lower doses of the drug to produce the desired therapeutic effect. We also, though, have adverse drug-drug interactions. Of course, a notable example would be our NSAIDs, our non-steroidal anti-inflammatory drugs. Those are taken together to increase, when taken together, when you take multiple NSAIDs together, they can increase gastrointestinal bleeding risk. So for instance, aspirin and ibuprofen, when taken together, they can both cause a bleeding risk and have an additive effect by interacting with each other. Now, food-drug interactions are, as you might imagine, when a medication is taken with food or drink, certain factors might increase or decrease the effectiveness in the drug or cause an increased risk of side effects. The classic example of this, as you can see right over here, causes a little cause of alarm, is grapefruit juice when taken with statins. And that happens to increase the risk of what's called rhabdomyolysis or rhabdomyolysis, otherwise known as the breakdown of muscles resulting in muscle pain. And lastly, we're not going to cover it too much, but you might see it in certain parts of the drug reviews. We do have drug-disease interactions, and that's simply when a drug has a worsening effect on the symptoms or progression of a specific disease. A very common one of these would be drugs that cannot be taken in renally impaired or people with chronic kidney disease. So for instance, metformin should not be used in patients with chronic kidney disease whose kidney function isn't very good, because metformin is hard on the kidneys. It gets cleared through the kidneys and it can cause kidney damage, which makes that kidney disease worse if in fact it is taken by a person who maybe does not have kidneys that are functioning to the best of their abilities. And that just about covers interactions. I'm going to stop it right here for the video, and you can pick up at the next part of the video where we'll talk about some specific drug-drug interactions. Thank you very much, and have a good one.